So I'm going to be demonstrating the placement of a Visualase catheter for ablation of the amydalohippocampal area for temporal lobe epilepsy. So basically, this is our setup that we use. We use the intraoperative CT scan, bring the patient in. We already have our MRI. We've already planned our trajectory. We place the patient supine with a bump over the shoulder of whatever side we're going to be treating. So just to orient you guys, this is the parietal occipital area on the left side, and this is the face here. So we've already done a CT scan. After the CT is performed, we want to check that accuracy. And let me see here. So, a couple things to check. We always check the pins because it's like you have 3 free fiducials. Always make sure that there's good registration there. You can check those. And that seems to line up pretty well. Those look good. And then we also check kind of inside the external auditory meatus to make sure everything lines up. So that looks good. So we're going to accept that. Great. We're going to let it fuse and see if it fused pretty well. This is not the actual patient, but that looks really good. So we're going to accept that. Let me get it done. Perfect. So I've already done my plan. We're going to go to the Varia guide next. So this is a Varia guide. I know Medtronic has an arm as well. You could use the Rosa Robot, Neuromate. These are all basically the same thing. So what we do here is you have your screen, you have your camera, and you want to line it up with your trajectory here. It really doesn't matter. You can do micro movements later. If you get the trajectory pretty well lined up, you don't have to make as many adjustments, but we can always make those. So we'll accept that. I use my finger here. That way you're not looking. It also tells you how far you are from the skull. So you can place your finger there, and it'll tell you that you're pretty close. A centimeter or 2 from the skull will be good. This is loose, so we'll accept that. So we'll lock that. And then you go through this. So basically, you get to be the Rosa or Neuromate, which is fun. This is a little fun exercise. And we like each one to be less than 0.2. Great. Sometimes it can be a little finicky. Good, we'll go next. Good. Okay, next. So, not quite where we want to be, but we're going to pretend those are all less than 0.2. So once we have our trajectory lined up, we go and we don't use any incisions here. We use a Steinman pin initially. We won't use this one today either for other reasons, but the reason we do this is as you're drilling, like I said, basically your entire trajectory is based on this bolt. Once this bolt's in place, your trajectory is fixed. So what we do first is we come down with a Steinman pin, we place it, that goes through the skin, and then we put that on the bone. Obviously, if you're doing this and anywhere there's thin bone, especially pediatric patients, you want to be very careful. And this is all, you don't see anything. This is all tactile feedback. So you want to go down and you want to make a little divot in the skull. What we found that is if you're not paying attention or you neglect this in any way, you can kind of walk down a little, or if this is the skull, then it kind of slides. And so we really got to pay attention. You can put some pressure inferiorly to make sure that it stays along its intended trajectory. And we'll start with that. Finally, after that's done, we come down and we use our drill, not this drill, but this bit. See if this will work. And once again, this takes you back to your initial training and putting in an EVD. Let's see here. All tactile, and you don't want to plunge. Once again, you can either have somebody irrigate your hands, and you want to have something to stop and keep your fingers here at all times so you're not going to plunge. You already have your... We've already used the Steinman, which we didn't use this time. Oh, thanks. Yeah. So can I have irrigate, mop my brow. And you want to make sure you don't drop your hand. I have a tendency initially using this to drop my hand, and that will, if the drill, it's a very snug fit, so you can actually fuse the drill within the cannula. And you kind of push and wait and make sure there's bone there. Kind of make sure there's still bone. There we go. Perfect. So, next thing we want to do is your arm stays in place. You don't want to, nothing's actually secured yet. Don't move the arm. That can happen, and then you got to start over. But you want to just back your stylet out, and actually what we're going to do is we're going to change out the inner cannula to make sure we have a snug fit. And this is exactly actually how we put in stereo EEG leads as well. Just the only difference is obviously what you're putting in, but the technique is the same. So we have our bolt. And let's back that up a little bit more here. Dun, dun. So this is going to secure our trajectory. So we can get this to sit. I think PMT also makes a bolt. We don't use that one or haven't used that one. But okay, so we're definitely in. You can feel now if you've actually been through the dura, but you certainly don't want to go down to target. So now that we're fixed, our trajectory is completely fixed, and we're locked into whatever this is going to tell us to go, right? So we can take this out of the way. Even take it off. And then we're going to check our basically depth to target. And so this tells us that starting here, it's 150.5 millimeters to target. So we get that. We're going to measure our rod here to 150.5 millimeters, and then just slowly place that to target. We've marked it. We know our depth, so slowly you want to be mindful. Once again, we have seen, especially in pediatric patients, that you can strip dura away easily, and there's not going to be that resistance, so you can cause epidural hematomas, or when you did your planning, you were mindful to avoid the sulcus or any arteries, but you can feel those sometimes, some resistance. So you want to be delicate, and you want to get past those. And so once we get to target, we're still debating this, whether to do 2 CTs or 1, but there's an option of doing a CT to make sure your trajectory, you can get a CT now, verify that to make sure your trajectory looks good, or you can just get one at the end. So we're set there. We want to loosen this up. So now we're ready to put in, basically this is the cooling sheath. This isn't actually the laser, but this is what we're going to introduce first. And then you have basically a stylet here to stiffen it. You want to be mindful also that this isn't cracked in any way. If this cracks, you're going to lose irrigation and you can heat up at that point. So you want to make sure that it's handled appropriately. We've also measured this to target. You can measure again. You don't want to forget, but ours was 150.5. We've measured that, and now we're going to place this to target. So let's say this was, and we've measured it. We're set. We're going to tighten that down just a little bit and take out. Well, I'm sorry. We're going to actually get a CT scan now to make sure it's in a good place. We've confirmed that. Looks good. We're going to take out our stylet. You're going to hold this up like this. If you drop it, it can bend, and you don't want it to bend a lot. A lot of the case after this in the transport is making sure this doesn't bend a whole lot. So you got to keep an eye on that. So then you're going to have your laser. Either the techs or the reps rather are going to are going to help you, and they're going to mark where actually the end of the laser is. So when this is placed here, and we'll show you that later, this you don't want to bend a lot. You're going to place this all the way down. This cannula is closed at the end, so once you don't really need to measure anything other than where this needs to be taken back from or when it's snug. So this has all been tightened, and you're ready to go to the MR suite. You take the patient out of pins, we go to the MR, and we'll start our ablation. Just to show you this now, and we'll step over to the software, but once you're in the MR suite, your job, once you've made an ablation, you're going to be pulling back, and basically you kind of just pinch your fingers, and you get a centimeter or so to pull back, and this marks it. This is sterile within the cannula, so as long as that hasn't been violated, you can advance it. We haven't had to do that yet, but you certainly could if you needed to go back and burn another area. That's it. Do you guys have any questions? Okay, great. Let's go do the ablation. Okay. Perfect. So, what is on my, oh, that's the. So, once you have the patient in the MRI scanner, the anesthesiologist will be securing everything. When you put the coil on, you want to be mindful of the catheter again. You don't want to bend it. You don't want it to be making any sharp turns at all, because basically that irrigation needs to be going the whole time, and you're going to have that as part of the setup here. So you're going to start the irrigation, and you're going to make sure that's getting good coolant of the laser. So we're going to start up. Oh, that's all right. But a little bit what we talked about before, you're going to choose two images, one in the sagittal plane. Certainly if you're doing hypothalamic hamartoma, you can do in the coronal. You're not going to move the catheter. But when you're doing the hippocampus, you want it in the axial and sagittal plane along the whole length of the catheter. So you're not having to choose other images. That's all right.
Sorry guys, one sec.
What's that? And just to remind you guys, I spoke about in the lecture about what the temperatures and what we actually need to denature or damage tissue, and anything over 45 degrees, and really maybe just a little bit below that, over 45, just at 45, it could be up to 60 minutes, which you obviously won't be doing in this case. But anything over 45 degrees can denature tissue. And so you want to, and we'll do this shortly, basically set your boundaries or your safety points for your software. And so 45 degrees is going to be set around the superior or the roof of the lateral ventricle where our optic radiations are, at the ambient cistern, just lateral to the cerebral peduncle, or whatever other, or even the base of the basal ganglia when you're burning. And because it can be difficult to pay attention to all those areas at the same time to make sure they're not having an increase in temperature. Your 90 degree or your upper limits are basically going to be just around the catheter or laser itself, and that is to prevent anything above 90. It basically will melt that sheath, and then the melted plastic can stick to your choroidal or your choroid plexus or your choroidal arteries, and we certainly don't want that. So those are the two boundaries that we're going to set. Does anybody have any questions? No. Okay. They can edit this out.
It's not really an MRI.
Okay, great. So we're acquiring our images. Also, it's nice to have the patient in the MRI scanner. It's kind of like having the patient awake, because if anything's going on, you'll see it. We had a patient with a very small subdural hematoma, and we were able to, we weren't worried because we were watching it not get bigger. So anyway, so we're going to set our targets here. These are our high targets. Our higher limit's 90. This low limit's set to 50. We might lower that to 45, but we'll set these at 50. So our high target, we're just going to set one now. I only have to set one, correct? So we'll set that one, and that's around the laser itself. So that's set, and then set phase, oh, sorry, not push screen. Destroys. Okay, great. So we've got our sagittal. We're along, the MRI tech has got it along the whole axis of the catheter. And then here's our axial view. And basically what you can do is here, you can go, sorry, I keep trying to touch screen. Oh, it is touch screen.
This one is.
Oh, this one's touchscreen. So you can go back between. We've already started the ablation. You want to go up to 30% power, and then once you confirm, here you have our historical lesion. So this little area, the software has decided that a lesion will have been, the temperature was high enough, long enough to cause a lesion there. And here's our live or actual lesion. The blue, then green, then these are all higher temperatures. I don't see a key, but anyway, so here's the actual. So you'll stimulate, say, and get it to, say, 45 degrees, and you know this is actually where the laser is heating up. We feel good about that, and then we can ramp up the laser itself. You have basically three things to increase your lesion size. You have time, you have the wattage of the laser, and then you have the irrigation. So time, you can wait there. At a certain point, it's going to plateau. And here you can see that the lesion's getting bigger. We still haven't. I'm sorry. The actual temperature is getting bigger, but we actually haven't caused much of a lesion yet. So we're going to keep that there. And then, sorry, having the same problem. You can turn up your wattage of the laser, and if that doesn't work, you can turn down your irrigation. And so you kind of have three things you can play with. So you can see here it's getting hotter, and we look, and now we're actually causing a lesion. And they've shown, Dr. Gross has shown multiple papers, that what you see here is really what you get on follow-up MRI. So it's pretty accurate as far as predicting the actual lesion you're going to get. So that's great. We talked about, and we will have set our load targets around, either on our sagittal, the roof of the ventricle, where optic radiations are, or here in the ambient cistern to protect our cranial nerves and PCA and PCOM. So once again, we're heating it up. You can see here, this is our actual temperature. It's pretty hot at the probe there. Our one target's safety target's at 85 degrees, and so you still have some room. You're still producing more lesion, and pretty soon we'll get as much as we can get, and we'll then move on to the next ablation, and we'll pull it back. And so you just do this probably about, in the whole length, it probably takes about 4 or 5 ablations. The whole treatment time is probably about an hour, not all with the laser on, but sometimes you'll struggle because you'll keep overheating or you'll keep going over one of your safeties and you have to play with it. But here you can see that we've moved it back and we're starting to heat up. And you can see how it's following, at least in this case, it follows the outline of the structure. And so the PIA, the CSF, and the vessels are going to be heat sinks and are going to prevent that lesion from passing past the anatomical structures, which is fabulous. What you don't get with, say, necessarily radio frequency ablation, and you wouldn't get this live feedback. Okay, great. At the end of it, we take the catheter out and put a single staple in, and they extubate the patient, go to the ICU. Most patients go home the next day. So, yeah. All right, thanks a lot.